Hi, my name is Dr. Marcelo Jimenez. I'm a cardiac electrophysiologist. That means that I'm a cardiologist who did additional training, subspecialty training to treat cardiac rhythm diseases. I see patients from all over Palm Beach County and neighboring counties here in South Florida. I'm part of a group called Florida Electrophysiology Associates. This video is meant to provide education on atrial fibrillation, also known as AFib, with a specific focus on describing catheter ablation of atrial fibrillation, which is a common treatment for the disease. Atrial fibrillation is the most common heart rhythm disease in adults. When I tell that to patients, sometimes they don't know that it's a disease, but it is. And like many diseases, unfortunately, it's progressive. In this case, as atrial fibrillation progresses, the episodes of atrial fibrillation happen more and more often, and they last longer and longer until the body's no longer able to correct this abnormal heart rhythm, and the patient stays in atrial fibrillation in a continuous fashion. Atrial fibrillation is a very common cause of stroke and of heart failure. When a patient develops atrial fibrillation, what happens is the top two chambers of the heart, called the atrium, are no longer beating in harmony with the bottom two chambers. When the top two chambers and the bottom chambers are not in synchrony, it can cause symptoms like fatigue. Fatigue is the most common symptom. It can also cause other symptoms like palpitations, lightheadedness. It can decrease exercise tolerance and other manifestations. Atrial fibrillation can also be completely asymptomatic, in which case sometimes it is detected on routine physical exam, or unfortunately, sometimes it is identified when people suffer the consequences of this disease, such as stroke or heart failure. Patients often ask me why they have atrial fibrillation. And the fact is, there isn't usually just one single cause for atrial fibrillation. Rather, there are cumulative risk factors that can lead to a diagnosis of atrial fibrillation. Some risk factors cannot be modified, such as aging or what we inherit in our genes. Other factors may be modified, but are often difficult to control, and they include weight management and excess alcohol intake. It can also be caused by poorly controlled blood pressure, damage to heart valves, or lung diseases such as COPD. There are other causes as well. When we diagnose atrial fibrillation, we discuss a few goals with our patients. We first want to make sure that we are protecting patients against stroke. We don't want anyone to have a stroke. That is often, but not always, something that involves the use of blood thinners. Next, we want to improve symptoms. This is a disease that can cause symptoms, and so we want to help people get rid of those symptoms. This means we want to get you to a state where you can continue to do the things that are most important to you in life without being limited by the symptoms that I described above. Improving symptoms often requires the use of medications to control the rhythm, but more and more often, in current medical practice, it involves catheter ablation of atrial fibrillation. And that is what I want to describe to you now. Catheter ablation of atrial fibrillation. We'll be talking about that in some detail. Remember, this is meant to be a general overview. This is definitely not a one-size-fits-all procedure, and it may not be suitable for every patient. The specifics for each patient, including specific recommendations, can only be made after reviewing the medical history and talking to a patient. In order to understand this procedure, we first have to discuss a little bit about how the heart beats under normal circumstances. The heart is electrically active. In fact, I'm an electrical heart doctor. And so for me, it's an electrical organ, and every single heartbeat occurs because electricity is spreading through the heart in a well-coordinated manner from top to bottom. Atrial fibrillation, very commonly, particularly in early stages of disease, originates from within structures called the pulmonary veins. Pulmonary veins are tube-like structures that bring oxygen-rich blood from the lungs back to a specific chamber of the heart called the left atrium. Sometimes there are faulty electrical signals that begin inside the pulmonary veins that should not exist, but they can stimulate the heart too quickly in a way that the heart cannot handle. And as a result, that signal degenerates into something called atrial fibrillation, which is a continuous, disorganized array of electrical activity. Catheter ablation of atrial fibrillation most commonly involves creating a barrier to prevent those abnormal electrical signals from inside those pulmonary veins from spreading and reaching the heart. In that case, even if those faulty pulmonary vein electrical signals occur and exist, they can't cause atrial fibrillation because they're unable to spread to the heart because of the barriers that were created. There are different technologies used to accomplish this task of creating those barriers, but for the most part, they often do something very similar, which is to disconnect the electrical signals from inside the pulmonary veins to the heart. The most commonly used technique is called radiofrequency ablation. Now, we have different tools available to us to perform radiofrequency ablation. It's a rapidly evolving field with a lot of investment in technology to make things better. And The most novel tool we have for radiofrequency ablation was approved in late 2023. It's a fantastic catheter called QDOT, which allows us to perform the procedure very efficiently and safely in a way that surpasses what we were able to do previously. It is important to know that even if atrial fibrillation is not present at the time of ablation, it does not impact outcomes because we can still identify the correct areas to address. In order to reach the areas of the heart where we need to work, we enter through large veins located in the groin area. These veins act as tunnels that allow us to introduce tools into the heart. We don't cut to enter these veins. Rather, it's like getting IV access, similar to ones you may have gotten in the past in your arms. Multiple different tools or catheters are used. Some of these tools allow us to see where we are inside the heart. Some are for creating a map that represents the particular patient's individual anatomy. And of course, one of the catheters is the one that allows us to perform the ablation. This procedure is performed under anesthesia, so patients really don't remember it. The entire procedure takes roughly 45 to 90 minutes, depending on multiple factors that are specific to each individual. Once your procedure is scheduled, you will be provided with a list of instructions to follow prior to your arrival. These will include discontinuing certain medications and not having anything to eat after midnight. On the day of the procedure, you will go through the check-in process at the hospital and complete any additional paperwork. Once admitted, you will have an IV placed and have initial blood tests done to run routine lab work. When ready, you will be escorted to the electrophysiology or EP lab, where the procedure will ultimately be performed. There will be multiple people in the room working together to get you through the process safely and efficiently. Adhesive patches will be placed on your chest and back to monitor your vital signs and to allow the technology required to create a map of your heart from the inside. Once patches are placed, anesthesiologists and nurse anesthetists will administer sedation. Following the procedure, you will have to lay flat for 2 to 4 hours. If you are recovering well with no major discomfort and no bleeding from the access site, you may be discharged from the hospital on the same day. In some cases, we recommend overnight stay for observation. For the remainder of the day after ablation, you should remain seated or laying down as much as possible, getting up only to use the restroom or to have something to eat. For 5 to 7 days following the procedure, you should avoid any strenuous activity such as lifting, pulling, pushing more than 10 to 15 pounds, which is a weight approximately equivalent to a gallon of milk. You can expect discomfort in your throat because of the tubes used by the anesthesiology team. There may be discomfort in the groin area because that is how we access the body. You may also experience discomfort in your chest area, related to mild inflammation of the areas that were ablated. Any discomfort experienced is typically mild and well tolerated. It usually resolves within a few days after the procedure. If discomfort in any of these areas is severe, then we need to hear about it in order to make sure that everything is okay. The first 2 to 3 days, you may also experience a mild fever, but this should subside. For 2 to 3 months after the procedure, you may still experience some symptoms of atrial fibrillation as your heart heals from the procedure. This is normal. It's a part of healing and does not mean that the procedure failed. We may recommend medication adjustment during this healing period to help with any symptoms that may occur. The first post-operative visit is usually 6 to 8 weeks after the procedure. You may be seen by a physician or a nurse practitioner sooner if necessary. This was meant to be a general overview, but I would be happy to review additional details in a more specific manner during a consultation. I hope that you find the information provided useful and that it helps answer some frequently asked questions about atrial fibrillation and about catheter ablation related to atrial fibrillation. Thank you.